You know that feeling? You're just tired, maybe putting on a little weight, not really changing anything major, forgetting things more often.
Yeah.
You kind of shrug it off, right?
Yeah.
Just life, stress, maybe getting older. But sometimes those little shifts, they could be pointing to something else.
That's exactly right. And today, we're diving deep into one condition that often creeps up like that, hypothyroidism. It
Mm-hmm.
affects millions, often very subtly.
Right.
Basically, think of it like your body's engine running low because the thyroid gland isn't producing enough of its, well, really crucial hormones.
And you've shared a fantastic set of sources with us for this deep dive. We've got
Mhm.
everything from detailed medical reviews to specific research papers, clinical guidelines.
Yeah,
It's quite a stack.
really is. There's a lot there. So our mission today is to take all that information you pulled together and really unpack it. Find the most important bits, the surprising things, and maybe the most actionable insights for you.
Actionable. Yeah.
We want to cut through the jargon and give you the clearest possible picture.
Okay, so think of this as your personal guided tour through the world of the underactive thyroid, all based on the material you provided. Let's get into it.
Let's do it.
So, maybe start right at the beginning.
Oh.
What exactly is hypothyroidism and why is it, such a big deal?
Okay, so at its very core, it's just a deficiency of thyroid hormone. These hormones, T4 and T3, they're kind of like the accelerator pedal for your metabolism.
Mm,
They influence, well, almost everything, heart rate, to how you burn calories, body temperature, you name it. So when you don't have enough, things just slow down.
okay.
And it's actually one of the most common endocrine or hormone disorders out there. The U.S. data you shared shows a pretty clear rise in how many people have. It went from about 9.5% back in 2012 up to 11.7% by 2019.
Wow, that's quite a jump in less than 10 years. So what's driving that? What are the main causes?
Well, it varies. In places like the U.S. where we generally get enough iodine in our diet, usually from iodized salt, the number one cause, by far, is autoimmune thyroid disease, specifically a condition called Hashimoto's thyroiditis.
Hashimoto's, that's where your own body attacks the thyroid.
Exactly. Your immune system gets confused and sees the thyroid as foreign, attacking it. But globally, the picture is different. Your sources make it clear that iodine deficiency is still the leading cause worldwide.
Really? Still?
Yeah, it affects something like 35 to 45% of the world's population. Huge numbers.
That really highlights how vital iodine is. Now, the sources mention this complex feedback loop, the hypothalamic-pituitary-thyroid axis. Can you break that down simply?
Sure, think of it like a thermostat system. The hypothalamus in your brain senses hormone levels. It sends a signal, TRH, to the pituitary gland, also in the brain.
Okay.
The pituitary then sends out TSH, thyroid-stimulating hormone, telling the thyroid gland in your neck to make its hormones, T4 and T3. If the thyroid isn't making enough, the pituitary senses this and ramps up TSH production, shouting louder, essentially.
Ah, got it. So high TSH means the brain is trying to wake up a sluggish thyroid.
Precisely. That's why measuring TSH is usually the first, and often the most sensitive, test for primary hypothyroidism, where the problem is the thyroid itself.
Okay, that clarifies things. But actually recognizing you might have, it sounds tricky because the symptoms are so, well, general.
They absolutely are. That's
Yeah.
one of the biggest challenges. Symptoms are often subtle. They overlap with just feeling run down or stressed, and they're not very specific to just this condition. Some people might not even notice any symptoms, especially early on.
So what are the most common things people might feel or that doctors look for based on the sources you sent?
Well, the list is long, but the really common ones that pop up again and again are things like fatigue, just feeling wiped out, weight gain, often without a clear reason, feeling cold when others are fine, cold intolerance,
Mm-hmm.
dry skin, hair loss, which frustratingly can take a while to grow back, even with treatment, sleepiness, muscle or joint aches, maybe some weakness. Also, mood changes like depression or just feeling emotionally up and down, forgetfulness, trouble concentrating, that mental fog. Constipation is common too.
Yeah.
And for women, menstrual cycle changes like heavier or irregular periods, and sometimes fertility issues.
That list, honestly, it sounds like half the people I know on a bad week.
Exactly. And that's why it often gets dismissed or overlooked for so long.
Yeah.
But there are other, maybe less obvious symptoms mentioned in your materials that
Oh,
are
yeah.
interesting.
Oh, yeah. Like what? Anything surprising?
Well, headaches were mentioned in about a third of patients,
Yeah.
and there might be a link with migraines, possibly going both ways.
Yeah.
That brain fog we mentioned, the lack of energy, forgetfulness, fatigue, One survey you found noted that over 17% of patients reported that not long after diagnosis. It's a very real experience.
Brain fog is such a perfect description for that feeling.
It really is. Other things. Obstructive sleep apnea may be linked to an enlarged tongue, macroglossia, carpal tunnel syndrome. Even recurrent vertigo, the positional kind, seems linked, especially with Hashimoto's, maybe suggesting the autoimmunity itself plays a role.
Wow.
And for men, sexual dysfunction like ED or low libido can be directly caused by the low thyroid state.
It really hits home how thyroid hormones affect, well, practically everything. Are there symptoms more specific to Hashimoto's itself?
Sometimes, yeah. People with Hashimoto's might feel a kind of fullness in their throat or notice their thyroid gland is enlarged but not painful. That's a goiter.
Yeah.
Deep fatigue is very common, and occasionally some transient neck pain or soreness.
And beyond what someone feels, what might a doctor actually see or find during an exam?
They might notice slowed movements or speech. Skin can be dry, sometimes even pale or slightly yellowish. Hair might look coarse, brittle, maybe thinning on the scalp, or even eyebrows and body hair.
Mm.
The face can look a bit puffy, especially around the eyes. That's related to myxedema, a type of swelling, an enlarged tongue, a hoarse voice, or that visible goiter we mentioned.
Okay.
Checking vitals, they might find a slow heart rate, bradycardia. Blood pressure might show a lower number, the diastolic being higher than usual. In really severe cases, body temp can be low. Reflexes might be sluggish, specifically the relaxation phase.
And you pulled out something interesting about masked hypertension.
Yeah, one study in your sources pointed to an increased risk of high blood pressure that doesn't show up in the clinic, masked hypertension even with mild or a subclinical hypothyroidism, another subtle connection.
So lots of subtle signs, but they can sometimes point towards something more serious. And speaking of serious, the sources mention myxedema coma. That sounds pretty alarming.
It is. It's the most severe form, a true medical emergency. It happens in people with long-standing, untreated, or severely undertreated hypothyroidism who then face a major stress like a serious infection, heart attack, stroke, certain drugs, or even just severe cold exposure.
What does that look like clinically?
The key signs are a major change in mental status, confusion, lethargy, even coma, very low body temperature, hypothermia, a significantly slow heart rate, problems with breathing leading to high carbon dioxide levels, and electrolyte issues like low sodium. It needs immediate, intensive hospital care.
Okay, definitely something to be aware of at the extreme end. Let's loop back to the causes then. We covered Hashimoto's and iodine deficiency. What else can cause the thyroid to underperform?
Right. Your sources cover a broad range. We generally categorize them into primary hypothyroidism, where the thyroid gland itself is the problem,
Okay.
and central hypothyroidism, where the issue originates higher up in the pituitary or hypothalamus, messing up the signals to the thyroid.
And Hashimoto's is the main primary cause where iodine isn't an issue.
Correct. It's that autoimmune attack we discussed. Immune cells infiltrate, causing inflammation and gradual destruction of thyroid tissue. Finding those anti-TPO antibodies is a hallmark, though they can sometimes disappear over time. Genetics definitely play a part. Your risk is about 9 times higher if a close relative has it.
And there was a mention of a possible link to thyroid cancer.
It seems debated.
Yeah, it's complex. Hashimoto's inflammation is often found near papillary thyroid cancers. Whether the chronic inflammation somehow promotes cancer, or the cancer triggers the immune response, or it's just an association that's still being researched. What about thyroid issues triggered by major life events, like pregnancy?
Postpartum thyroiditis is a key one there. It happens after delivery, more often in women with type 1 diabetes or high thyroid antibodies during pregnancy. Interestingly, it can start with a temporary hyperthyroid phase, too much hormone, before swinging to hypo.
Is it usually permanent?
Often it's transient, lasting a few months up to a year. But one long-term study you found showed that about 38% of women who'd had it eventually developed permanent hypothyroidism later on, compared to only 4% who hadn't.
Significant risk then. Are there other kinds of thyroid inflammation?
Yes, there's subacute thyroiditis. It's less common, often painful, causes transient hyperthyroidism, and seems linked to viral illnesses. Your sources even mention studies connecting it to COVID-19.
Interesting.
And then there's renal thyroiditis, which is very rare. It involves dense, scar-like tissue making the thyroid feel rock hard. It's sometimes linked to a broader systemic condition involving fibrosis.
And other autoimmune conditions can overlap.
Absolutely. Systemic lupus erythematosus, SLE, is a good example. Hypothyroidism is the most common thyroid issue in people with lupus, affecting maybe 15–19%. especially younger patients and women.
It seems like a busy immune system can sometimes misdirect its fire towards the thyroid.
That's a good way to put it. And then moving away from diseases, medical treatments themselves can be a cause.
Like treatments for other thyroid problems.
Yes, definitely. Radioactive iodine, often used to treat an overactive thyroid and Graves' disease, very commonly results in permanent hypothyroidism, usually within 3 to 6 months.
Makes sense.
And surgery, removing the whole thyroid, obviously causes it. Removing just a lobe, a lobectomy, carries about a 15–30% chance of needing hormone replacement afterwards.
What about treatments for things completely unrelated to the thyroid?
This is really important to highlight it in your sources. Radiation therapy to the neck area for head and neck cancers, lymphoma, can significantly damage the thyroid.
Hmm.
The risk is quite high, maybe 40–50% incidence after substantial doses.
Wow.
And then there's a list of medications. Some are well known, like amiodarone for heart rhythm, lithium for mood disorders, interferon alpha.
Right.
But also, newer cancer drugs are significant players. Certain targeted therapies, called tyrosine kinase inhibitors, or TKIs, drugs like sunitinib, and the immune checkpoint inhibitors, ICIs, like ipilimumab or pembrolizumab.
How do those cancer drugs cause it?
The mechanisms vary. TKIs might directly harm thyroid cells or affect blood supply. ICIs work by ramping up the immune system to fight cancer, but sometimes that boosted immunity turns on healthy tissues, like the thyroid. Hypothyroidism from ICIs is often permanent. Interestingly, one source noted that developing hypothyroidism while on some TKIs seems linked to better cancer survival, but they don't fully understand why yet.
That is fascinating. So it's a real mix: autoimmunity, nutrition, inflammation, genetics, medical treatments, drugs.
Wow. Given all that and the subtle symptoms, how do doctors actually pin down a diagnosis?
The workup usually starts with blood tests.
Yeah.
And the key initial test, especially for primary hypothyroidism, is that TSH level we talked about. The modern third-generation TSH assays are very sensitive.
Okay.
The typical normal range is roughly 0.4 to 4.2 MIUL, though your sources correctly note it can creep up a bit as people get older.
And if that TSH comes back high, a high TSH means the pituitary is yelling. So the next logical step is to check how the thyroid is responding, specifically by measuring the free T4 level. T4 is the main hormone the thyroid makes, and measuring the free or unbound portion tells you how much active hormone is actually available to the body's tissues.
Why free T4, not just total T4?
Because most T4 in the blood is bound to proteins. Things like pregnancy or certain medications can change those protein levels, affecting total T4 without changing the active amount. Free T4 gives a clearer picture, though it's a bit more complex to measure.
So high TSH plus low free T4 equals classic primary hypothyroidism.
Exactly. That's the textbook picture for overt or clearly evident primary hypothyroidism. Now, if the TSH is high, but the free T4 is still within the normal range, that's generally classified as mild or subclinical hypothyroidism.
So the brain's yelling, but the thyroid is just managing to keep up.
Pretty much. The TSH is elevated, maybe in the 4.5 to 10 range usually, but the active hormone level hasn't dropped below normal yet. And that's where a lot of the treatment debate comes in, which we can discuss later.
Right. What about testing T3, the other main thyroid hormone?
Your sources generally advise against routine T3 testing for diagnosing hypothyroidism. The body is pretty good at maintaining T3 levels early on, often by converting more T4 into the more active T3. So T3 can look normal even when T4 is starting to fall.
Okay, so focus on TSH and free T4 initially. What about antibody tests like anti-TPO?
Testing for anti-TPO and sometimes anti-thyroglobulin antibodies is really useful for figuring out the cause. Is it autoimmune, like Hashimoto's? It can also help predict who might progress to needing treatment. But once you know antibodies are positive, repeatedly checking their levels generally doesn't guide treatment decisions.
Got it. The sources also mention situations where labs can be misleading, like serious illness.
Yes, that's a critical point. In someone who's very sick with another condition, say, in the ICU, their thyroid tests can look abnormal, even if the thyroid isn't the root problem. It's called non-thyroidal illness, or sometimes euthyroid sick syndrome.
How does that look?
TSH might be low or normal. Total T4 can be low. T3 is usually decreased. It can mimic central hypothyroidism on paper. So interpreting thyroid tests in critically ill patients needs real caution. Often it's better to wait until they recover unless thyroid disease is strongly suspected.
And for actual central hypothyroidism, the brain signal problem, how do those labs differ?
In central hypo, the pituitary isn't sending enough TSH. So you'll see a low free T4 level, but the TSH won't be appropriately high, might be low, or maybe inappropriately normal for that low T4. That's why you absolutely have to measure free T4 if you suspect central causes. TSH alone is insufficient.
Okay. Are there other general lab abnormalities sometimes seen with hypothyroidism?
Yeah, sometimes you see mild anemia. Cholesterol levels, particularly LDL, can be elevated. You might see slightly low sodium levels due to changes in water balance, or mild elevations in liver enzymes or muscle enzymes like CK. And as mentioned, primary hypo can sometimes cause mildly elevated prolactin levels.
When does imaging, like an ultrasound of the thyroid, become necessary?
Ultrasound isn't routine for just diagnosing hypo, but it's very useful for looking at the thyroid structure. If a doctor feels a lump or nodule, or if they suspect Hashimoto's, an ultrasound can show characteristic changes like a diffuse, patchy, hypoechoic appearance in Hashimoto's.
And for nodules?
Ultrasound is key for evaluating nodules, checking their size and features. If a nodule looks suspicious, irregular borders, microcalcifications, etc., or if the patient has risk factors, an ultrasound-guided fine needle aspiration biopsy is usually the next step to check for cancer.
Makes sense. Lastly, on diagnosis, what's the verdict on screening everyone? Say all adults.
There's still no universal consensus on screening all asymptomatic adults. Different expert groups have slightly different takes. The American Thyroid Association, for example, recommends screening for specific high-risk groups. People over 60, pregnant women or those planning pregnancy, individuals with type 1 diabetes or other autoimmune conditions, people with a strong family history, or those who've had neck radiation. ACOG, for pregnancy, focuses on screening high-risk individuals rather than everyone. So it's more targeted screening than universal generally.
Okay, so once it is diagnosed, how do we treat it? What are the goals?
The goals are pretty clear. Replace the hormone that's missing, make the person feel better by resolving their symptoms, and get those lab tests, especially TSH and free T4, back into the normal range.
And the main treatment is?
The gold standard, universally recommended in your sources, is synthetic T4. The generic name is levothyroxine, often called LT4.
How do doctors figure out the starting dose? Seems like it could vary a lot.
It does. The typical full replacement dose for a generally healthy adult averages around 1.6 micrograms per kilogram of body weight per day. But you don't always start there. Younger, healthy people might start closer to their estimated full dose. But for older adults, say over 60 or 65, or anyone with known heart disease, it's crucial to start low and go slow. Maybe just 12.5 or 25 micrograms a day, increasing very gradually every 4 to 6 weeks.
Why the caution?
Because suddenly increasing thyroid hormone can put extra strain on the heart. You want to avoid triggering chest pain or arrhythmias. For many people with mild or moderate hypo, starting with 50 or 75 micrograms daily might be enough initially. Pregnant women need higher doses, often about 25% more, right from the start.
How long does it take to work? When do people feel better?
Some clinical benefits might kick in within, say, 3 to 5 days, but it takes about 4 to 6 weeks for hormone levels to fully stabilize after a dose change. So you typically wait that long before rechecking TSH and deciding on the next adjustment. Getting the TSH perfectly in range can sometimes take a few months of tinkering.
And once the dose is stable, how often do you need checks?
Once stable, monitoring is usually less frequent. Maybe an annual checkup with a TSH test, sometimes every 6 months, along with discussing any symptoms. It's also really important to watch for signs of overtreatment.
Right, taking too much. What does that look like?
It can feel like hyperthyroidism, fast heart rate, palpitations, feeling anxious or jittery, tremors, trouble sleeping, increased sweating, feeling hot, maybe diarrhea or weight loss.
Are there serious risks from being overtreated long-term?
Yes, definitely. Your sources highlight increased risk of atrial fibrillation, that irregular heart rhythm, especially in older adults, if the TSH is pushed too low, suppressed. There's also concern about bone health overtreatment, especially chronically suppressed TSH, is linked to decreased bone density and increased fracture risk, particularly in postmenopausal women.
So careful monitoring is key. What if someone's TSH level is perfect on LT4, but they still feel lousy, still tired, still struggling with weight?
That's a common frustration. The first step, emphasized in your sources, is to look for other reasons for those symptoms. Are there other health issues? Lifestyle factors? It's important not to just keep pushing the LT4 dose higher if the TSH is already normal because of those overtreatment risks.
Is there ever a case for adding T3?
It's mentioned as a possibility in very specific rare situations. For instance, maybe someone has a genetic variation that affects how their body converts T4 to the active T3. In those carefully selected cases, under an endocrinologist's guidance, a combination of LT4 and a small amount of synthetic Key 3, liothyronine, might be tried, aiming for a physiological ratio. But it's definitely not standard practice and carries its own risks.
Okay. And taking the LT4 correctly seems really critical for it to work properly.
Absolutely crucial. LT4 is mostly absorbed in the small intestine, and lots of things can interfere. Gut conditions like celiac disease, H. pylori infection, inflammatory bowel disease, even just gastritis or having had bariatric surgery can reduce absorption.
What about interactions?
Huge issue. Your sources list common culprits. Iron supplements, calcium supplements, including calcium-fortified foods or drinks, aluminum-containing antacids, sucralfate for ulcers, certain cholesterol drugs, even things like walnuts, soybean flour, high-fiber foods. You need to separate your LT4 dose from these by at least 2 to 4 hours, sometimes longer.
Wow, that requires some planning.
It does. And things like coffee might also interfere if taken too close together. If someone's on continuous tube feeding, the feed needs to be stopped for maybe 30 to 60 minutes before and after the dose. Consistency is key.
What about timing? Always first thing in the morning.
Traditionally, yes, taking it on an empty stomach at least 30–60 minutes before breakfast was the standard advice, and it works well for many. But your sources also confirm that taking it at bedtime, several hours after the last meal, is another effective option, and might even lead to better absorption for some. The most important thing is picking a time and sticking to it consistently, away from interfering substances.
And things like pregnancy or birth control pills can affect the dose needed.
Yes, estrogens increase the levels of thyroid hormone-binding proteins in the blood, which can mean you need a higher LT4 dose to maintain the same level of free active hormone.
We touched on synthetic T3, liothyronine, briefly. Is it ever used alone?
Not really for ongoing maintenance. LT3 has a very short half-life, meaning it doesn't last long in the body, leading to peaks and troughs in hormone levels. It's primarily used intravenously in emergencies like myxedema, coma, or sometimes that combination therapy we mentioned, but always with LT4 and careful monitoring due to higher cardiac risks.
And the natural desiccated thyroid products from animal glands.
Yeah, these contain both T4 and T3, typically from pigs. The main issue, highlighted in your sources, is the variability in the T3 content from batch to batch, and the T4.T3 ratio isn't the same as human physiology. This makes dosing less precise and increases the risk of T3 side effects like palpitations. So synthetic LT4 is generally preferred for its consistency and safety profile, especially in pregnancy or people with heart conditions.
Let's revisit myxedema coma treatment quickly. You mentioned IV LT4. What was the critical point about steroids?
Absolutely critical. You must give intravenous glucocorticoids, high-dose steroids, either before or at the same time as the IV thyroid hormone.
Why again?
Because severe hypothyroidism, particularly if it's central in origin, can coexist with adrenal insufficiency, the adrenal glands not making enough cortisol. Giving thyroid hormone alone in that situation can precipitate a life-threatening adrenal crisis because thyroid hormone increases cortisol metabolism. So you always cover with steroids first to be safe. Then supportive care, warming, treating infections, etc. is vital.
Got it. Super important distinction. Now, let's talk about specific populations, starting with pregnancy. Huge implications there.
Massive implications. Your sources are very clear. Untreated or even undertreated hypothyroidism during pregnancy is bad news. For the mother, risks include anemia, higher chances of miscarriage, preeclampsia, postpartum hemorrhage, even cardiac problems.
And for the baby?
For the baby, risks include low birth weight, preterm birth, and crucially impaired neurocognitive development. Some studies link maternal hypothyroidism to lower IQ scores and increased risk of ADHD or autism spectrum disorder in the child. Fetal mortality risk is also higher.
So screening seems like a no-brainer, but you said it's still debated.
It is, somewhat controversially. ACOG, the obstetrician group, recommends screening high-risk women, while the Endocrine Society advocates for universal screening early in pregnancy or preconception. The reality is, historically, many women likely went unscreened.
And hormone needs definitely go up during pregnancy.
Significantly, usually by about 25%, sometimes more, often starting very early in the first trimester. If a woman is already on LT4, her dose will need to be increased, usually proactively. Adequate iodine intake is also essential. The guidelines recommend 150 micrograms daily supplement for women planning pregnancy, pregnant, or lactating.
How often should TSH be checked?
Frequently. For diagnosed hypothyroidism, typically every 3–4 weeks during the first half of pregnancy, then maybe every 6–10 weeks in the second half. The goal is usually to keep TSH below 2.5 MIUL in the first trimester and below 3.0 in the later trimesters, using trimester-specific ranges. Dose adjustments need rechecking 3–4 weeks later.
What happens after delivery?
The dose requirement usually drops back down quickly, often to the pre-pregnancy level. Checking TSH around 6 weeks postpartum is recommended. Your sources also delve into managing subclinical hypo or just positive antibodies in pregnancy, which is complex, with ongoing research about potential benefits of treatment for preventing miscarriage or preterm birth in some cases.
And the practical tip, don't take LT4 with prenatal vitamins.
Yes, separate them by several hours due to the iron and calcium, crucial for absorption.
Okay, another tricky area. Subclinical hypothyroidism outside of pregnancy. That TSH between, say, 4.5 and 10 with normal free T4, treat or not treat.
This is a major point of discussion and differing opinions in your source materials. There are arguments for treating, especially if TSH is closer to 10 or if the person has symptoms, positive antibodies, predicting progression, or maybe high cardiovascular risk factors.
What are the potential benefits cited?
Some studies suggest treatment might improve subtle symptoms, possibly slow progression to overt hypo, and maybe offer some cardiovascular protection like improving cholesterol levels or reducing arterial stiffness. One source mentioned it might help iron deficiency anemia respond better to iron treatment.
But the evidence isn't universally convincing.
Exactly. Many guidelines and a large randomized trial called TRUST, specifically in adults over 65, found no significant benefit of treating subclinical hypo, TSH 4.5 to 10, on quality of life, thyroid symptoms, cognitive function, blood pressure, or cardiovascular events over a year or more. The USPSTF also found insufficient evidence for broad benefits outweighing harms.
So what's the approach then?
Your sources suggest it's often a case-by-case decision, especially factoring in age. For older adults, say over 65 or 70, especially if TSH is only mildly elevated, like 4.57, observation is often recommended. If TSH is persistently over 10, treatment is more often considered, but still individualized based on symptoms, antibodies, and overall health. Younger patients might be treated more readily, especially with higher TSH levels or symptoms.
And briefly, infants and children.
Congenital hypothyroidism, being born with it, is screened for at birth in the U.S. and many places because early treatment is absolutely vital to prevent permanent intellectual disability. Most brain development happens in the first couple of years.
So newborn screening catches it.
Yes, and it's readily treatable with LT4. If missed, the consequences are severe. The term cretinism historically referred to this severe form, often caused by maternal iodine deficiency, but widespread screening and iodine supplementation have made that much rarer. Older children diagnosed later might have growth issues, but usually avoid the severe neurological impact.
Okay, so shifting gears slightly beyond the medical details, how does someone actually live with this day to day? What's key for patient education?
Understand it's usually lifelong is step one, lifelong LT4 therapy. Then really grasping how to take the medication properly, the timing, avoiding those interactions is critical for it to work well, and committing to regular follow-up, at least annual TSH checks once stable, to make sure the dose remains correct.
Any special diet needed?
Not specifically for the hypothyroidism itself, other than ensuring adequate iodine intake where that's relevant globally. The main dietary point is being aware of those foods and supplements, soy, high fiber, calcium, iron, that interfere with LT4 absorption, and timing the medication accordingly.
What about physical activity? Any restrictions?
When hypothyroidism is uncontrolled, people might have muscle weakness, poor coordination, or slower reaction times. So caution might be needed with activities that carry a high risk of falls or injury until hormone levels are normalized. Some sources mention a theoretical increased risk of ligament injury due to tissue changes, suggesting avoiding excessive joint force.
And when does someone being treated for hypothyroidism need to consult a specialist, an endocrinologist?
Your sources give a good list. If thyroid nodules are found or there are symptoms of neck compression, definitely during pregnancy or when planning pregnancy, if they have coexisting heart disease or other endocrine disorders, if the patient is a child or adolescent, if central hypothyroidism is diagnosed, if lab results are confusing or don't match the clinical picture, if symptoms persist despite seemingly adequate treatment, or if there's rapid goiter growth, raising concern for rare issues like lymphoma. And obviously, suspected myxedema coma is an urgent referral or ER visit.
Okay, wow, that was incredibly thorough. We've really journeyed through the landscape of hypothyroidism, guided by the sources you brought. Started with those vague feelings, dug into causes like Hashimoto's and iodine issues, navigated the tests, detailed the mainstay LT4 treatment, and covered specific situations like pregnancy and subclinical states.
Yeah, it's a lot to cover. Hopefully, Walking through the material you provided has helped distill those key takeaways and given a clearer sense of just how multifaceted this common condition really is, from diagnosis through to long-term management.
And thinking about it, how often those early symptoms, the fatigue, the weight gain, might just be brushed off as getting older or being stressed. And then you have these real medical debates about treating milder cases, the long-term effects on heart and bones.
It absolutely raises a really important point, doesn't it? How
Yes.
can we as individuals be more aware of these potential signs? And how can the healthcare system ensure this, well, sometimes sneaky condition isn't missed, and that treatment is genuinely personalized and optimized for each person?
Definitely something to ponder. A great point to end on until our next deep dive.